Hi everyone, I am Dr. Diksha Pandey and you are watching Urogynecology for Beginners. Since long time we have been posting the surgical videos. Today we decided after a long time we are going to discuss a case today, and for that I have with me Dr. Suvriti Bansal and Dr. Dheera Samdaria, who are my cute fellows 2022-23, the first fellows. So they are going to present the case. Who wants to start the history?
I'll start with history, ma'am.
Okay.
Miss X, 55 years old, postmenopausal since 5 years. She had come to us with two specific complaints. One was involuntary passage of stools and involuntary passage of urine. Involuntary passage of urine on coughing, sneezing, laughing since 4 years, and involuntary passage of stools since 6 months.
Okay,
Yes,
what is
ma'am.
the age you said?
Ma'am, she is 55 years old.
And postmenopausal.
Postmenopausal from Manipal, a local political leader.
Okay.
Yeah.
And she's a
Local political
leader.
Yes.
Okay. So she presented some few years ago when
Yes,
she was
ma'am.
premenopausal
Yes, ma'am.
with complaint of urinary incontinence.
Yes.
And now she also has some kind of fecal
Fecal
incontinence.
yes, ma'am.
Okay. Anything else you would like to tell
Yes,
in
ma'am.
the detailed history?
Yes, ma'am. Her complaint started with involuntary passage of urine on coughing, laughing, and sneezing. This is her initial complaint. This started around 4 years ago. She sought help that time. She was given antibiotics and explained about pelvic floor muscle training. She tried to do that, but she was not consistent. Again, when she had shown, the same treatment was given to her. After that, she developed the complaint of involuntary passage of stools, for which in a local hospital here, she underwent proctoscopy. There was no anatomical defect that they had noted that time, and again she was told about pelvic floor muscle training for this as well. When this worsened and she started to soil her clothes and everything, she sought more help, and a transperineal ultrasound was done at that time for her. In that ultrasound, ma'am, they had seen that anteriorly the sphincter was totally absent. So after that, she was referred over here and she came to urogynecologists finally.
Okay. Any comorbidities and her obstetric history, if you
Yes,
want
ma'am.
to tell?
Ma'am, she has no medical comorbidities, but she has undergone 2 deliveries. The last one was around 20 to 25 years back. Both babies were big, ma'am. Both babies 3.6 and 3.8. She gives history of prolonged labor, but until 4 years ago, none of these complaints were there. Post delivery, she does not give any complaints like that.
Okay. All started when she is going into menopause.
Yes, ma'am.
Okay.
Yes, ma'am.
And she has been evaluated for fecal incontinence.
Yes, ma'am,
mode,
she has.
and she has been given repeated course of antibiotics and PFFT for her urinary incontinence.
Yes, ma'am.
But she is not happy with that.
Not happy with that.
Okay. And I hope she has a good quality, active life.
Yes, ma'am.
She is a local political
Well spoken, well educated. Yes,
patient. Okay. And she has been suffering for last
4 years. Yes.
Okay. Then let's move on to the examination. Okay. Then we'll discuss the further things.
Ma'am, patient was moderately built and nourished. Her gait and thyroid were normal. Her vitals were stable. Her systemic examination was normal.
Okay.
Ma'am, on per abdomen examination, she had the sterilization scar. Otherwise, on local examination, ma'am, on uniform cough stress test, SUI was demonstrable.
Okay.
And ma'am, there was excoriation seen around the anus.
Okay. So mostly because of fecal incontinence.
Yes, ma'am. Ma'am, and then on per speculum, she had grade 2 uterine descent with, she had a second degree uterine descent with grade 2 cystocele with a minimal rectocele. But ma'am, what you always say to check for, there was absent of sun raying from the 9 o'clock to the 3 o'clock position. Otherwise, the levator tone was moderate, and on per rectal examination, ma'am, the sphincter tone was very poor.
Okay, so she had all kinds of defects.
Yes,
actually. She had urinary incontinence, she had cystocele, she had uterocervical descent, she had loss
minimal
of
rectocele,
minimal
lax
perineum,
Yes,
and loss of sphincter.
Sphincter
also.
tone. Yes, ma'am.
So, as far as I can understand this case, maybe the patient had, as we expect normally, that she had sustained some injuries during the childbirth.
Yes, ma'am.
You also told that the babies
Yes,
were
ma'am.
good size
Good
babies.
size babies,
3.8.
prolonged labor and both.
Prolonged labor in both deliveries.
Yes, ma'am.
Good size babies, but no history of instrumentation.
Yes, ma'am.
So it looks like a clear-cut case to me, like maybe she sustained all this trauma during her childbirth, but she was not symptomatic because of her good estrogen.
Yes.
And when the estrogen started declining in her body, nearing menopause, then slowly all symptoms started presenting. And the one important thing, she has not told about any bulge.
No, ma'am.
Though she has minimal rectocele,
Yes,
some
ma'am.
cystocele,
It
and
wasn't her
uterine descent.
complaint.
And maybe her threshold of presentation also was a little bit high.
High, yes, ma'am.
Because otherwise some women present to us with that kind of bulge
Yes,
in the
ma'am.
vagina, sexual dysfunctions, problems like that. But this lady had not presented with these symptoms.
Yes, ma'am.
And I would emphasize again what Dhira was trying to tell,
Yes.
loss of sun drain.
Yes, ma'am.
It is a very, very important sign when you examine a patient with pelvic floor disruption. And she said that 3 to 9 o'clock the
Yes,
sphincter
ma'am.
was deficient.
Hmm.
And if we recall in history, you also told that when
Yes, ma'am.
transperineal
Anterior
ultrasound was
ultrasound.
there,
Yes, ma'am.
and entirely the sphincter was
Absolutely.
deficient. So what I want to give an important message here is that for every patient who complains of fecal incontinence or even flatus incontinence, okay, let's come back to one more important area here. So we'll discuss about the sun drain. But this is one important thing which we have to understand. Some urologists have seen her.
Yeah.
They have looked into her urinary complaint, given
Yes, ma'am.
antibiotics and PFMT for her. Some colorectal surgeons have seen her,
Yes, ma'am.
and they have looked into the fecal incontinence, done proctoscopy and other investigations, have not found anything. Now, as a gynecologist, there is like central compartment defect also, anterior defect
And
also,
posterior.
prolapse, you can say in easy words. So if one person sees all these things in totality, that is much better than the treatment can be quicker to the patient,
Yes,
and
yes.
understanding of problems can be better and more fruitful. The outcome can be good,
Yes,
rather than 3 individuals seeing the same defect at different places.
Yes,
right,
Basically,
yes,
it is a defective pelvic floor. Okay, so there is no harm in giving PFMT, but this is the routine, regular cases which we see, that patients are told about pelvic floor muscle training, but follow-up is difficult. Patient are not compliant to this kind
Yeah.
of therapy. And the second thing is regular antibiotics to treat SUI also is very common practice, which we
Yes.
keep on seeing. Okay, now as a urogynecologist,
Yes,
okay, we can treat all of this together. Okay, so coming back to the sun-ray pattern, so sphincter usually makes a sun-ray kind of pattern around the anal verge.
Yes,
All around that sun-ray should be there, which is because of the skin folding above the external
In
anal
a
sphincter.
sphincter. Yes.
Now, when you are saying that sphincter was deficient from 3 to 9 o'clock position, 3 to 9
Nine,
o'clock
yes.
position, that does not mean that that part is actually missing. So I always tell, this is one of my favorite things for understanding, that internal anal sphincter is a sheath of muscles
Yes.
which is coming from the entire intestine. It is
Yeah.
the muscle layer. While external anal sphincter is like a rubber band at the verge of it. So when you cut that by chance because of injury during childbirth, it is not that entire segment is lost.
Right, yes.
When there is a cut or breakage in the sphincter, like rubber band, it goes inside and retracts and hides itself in the muscles and soft tissues there.
Yes.
And slowly, when you see it after many years, it gets fibrous there and difficult to retrieve those edges. So the defect actually is more or less linear at a single point,
Yes, ma'am.
Yes.
rather than a loss of segment. This understanding is also very important. And as far as my experience is concerned, I can tell you with certainty now that whenever the sun raying is such an important sign, whenever a patient complains of these kind of posterior compartment incontinence, you always see the sun raying. And if it is deficient in a certain segment, you don't have to even do an anal or rectal or transperineal ultrasound. You will always find the corresponding defect.
Yes.
So you can rely on your eyes If sun draining is absent, that means the sphincter has gone from that side.
Yes,
Okay.
And so quick to do in the OPD also,
Yes,
ma'am.
yes. It's just you have to just look at
Look
it
at
and
it,
you will
yes.
know. It doesn't require any test or anything. Okay, so all these defects were there.
Yes, ma'am.
Any treatment was given for her fecal incontinence, or just diagnosis was made?
No, ma'am. Actually, when she had gone, firstly, when they had done the proctoscopy, that was the first time she was seen. So they just advised her pelvic floor muscle training for that, for fecal incontinence also. And only when it worsened, she started to soil her clothes. Then the transperineal ultrasound was done. This defect was noted, and she was referred.
Okay. So now again, one important thing in urogynecology. First thing is you have to identify the anatomical defect, which is
Yes,
caused
ma'am.
because of childbirth. And whenever there is anatomical defect, that has to be repaired as first line.
Yes, ma'am.
Okay. And secondary, as an adjunct, you can strengthen the nearby surrounding muscles and can stimulate the nerves. If you follow this in a different order, in an opposite order, like you start strengthening the muscle, it might be of little help.
Yeah.
In very mild cases, that muscles take over it and nerve stimulation can help little bit. But most important, till the integrity is not there, anatomy is not created again as it should be, usually muscle strengthening and nerve stimulation might not be that effective.
Yes.
Yes,
So first step always should be
Anatomy.
restoring the anatomy, then helping her with physiotherapy and what?
Nerve
Stimulation,
modulation.
nerve,
Yes.
neuromodulation.
Yes.
Okay. So usually in SUI, okay, when it is not demonstrable or it is very mild, patient is young, her
Yes,
muscles
ma'am.
have good tone,
Yeah.
you can try
with
a trial
PFMT.
of PFMT. That is the easiest treatment because it
Yeah.
does not have a side effect. But you cannot keep on waiting for years
Yes,
together.
ma'am.
For 4 years, patient is so agonized, she has
Yeah.
no help for it.
Yes, ma'am.
So that should be looked into. Now coming again to fecal incontinence, because urinary incontinence we have discussed many times. It is a clear-cut case of SUI. You told she is giving typical history
Yes,
of
ma'am.
a slowly increasing SUI, and
yes,
you
ma'am.
gave typical examination that uniform cough
Cough
stress
stress
was positive.
yes.
So there is no doubt. She does not have any
No, ma'am. No
component of
urgent urgent
no
continence.
mix. It is not a mixed. It is a clear-cut case of simple SUI.
Yes,
That is
ma'am.
one thing.
Yes, ma'am.
Second thing, now coming back to fecal incontinence.
Yes.
Now, fecal incontinence, whenever patient asks, says that she has fecal incontinence, what most important question you are going to ask?
Ma'am, we have to rule out if it is associated with urgency.
Very good. So this patient, if I remember it
Yeah.
well, she said specifically that morning she gets a urgent desire to pass.
Yeah.
And by the time she reaches the washroom, she has
She has
already
already
soiled
passed.
her
Yes.
Clothes.
undergarments.
Yes,
Okay. So urgency is very, very important, because why it is important? Whenever there is urge component,
Yeah.
that means sensory somatic involvement is there.
Yes.
And if you remember the physiology lecture, you will remember that
Yes, ma'am.
sensory supply is only for
Internal
sphincter.
in external sphincter. Sensory supply.
Okay.
Sensory is pudendal nerve supply
Pudendal,
is
yes.
only the
External anal
external.
sphincter.
Pudendal autonomic nerve supply for all others.
Is,
Pudendal
yes, ma'am.
nerve.
Pudendal nerve supplies the external
External
anal
anal
sphincter. So whenever patient has desire, that urgency, and after that she soils, that is always associated with some problem in external
External
anal
anal
sphincter.
Yes, ma'am.
So with that, would anybody like to tell a little bit about causes of fecal incontinence? What can be the other causes of
Causes.
fecal
Okay, ma'am. Ma'am, so causes of fecal incontinence, firstly, it will be the obstetric injuries. Ma'am, and it usually, even medical comorbidities can be like diabetes, obesity, and menopause, increasing age, loss of estrogen, basically.
So these are the more important for
yes,
us.
ma'am.
So when we describe this fecal incontinence, patient can present with two kinds
Yes,
of
ma'am.
incontinence. One is
Urgent
urgency
and
Yes.
passive.
incontinence, and the other is fecal passive soiling.
Passive soiling.
Passive soiling. Now, what causes passive soiling?
Ma'am, any nerve-related defect?
Passive soiling is because of the defect in
Internal
internal
sphincter.
sphincter.
Okay.
Internal sphincter defect will cause. If external has good tone,
Yeah.
there can be such obstetric injuries also where external sphincter is Okay.
Okay, yes,
But
ma'am.
internal has got torn.
Okay, ma'am.
So those cases will present with passive.
Passive
Okay,
soiling.
ma'am.
And even rectocele.
Yeah.
Okay, because of outpouching of rectum into
Yes,
the
ma'am.
vagina,
Will
there
keep
will be
getting
impaction
impacted. Yes,
of
ma'am.
stools there.
Yeah.
And whenever it becomes too full distance, so patient without her knowledge, she will
She
start
will
soiling.
evacuate. Yes.
And if external sphincter is still very tight, she will
Yeah.
have constipation. If on top of that also, if there is external sphincter is intact, then patient again can complain of
Overflow type.
overflow kind of
incontinence.
incontinence, that is called passive soiling.
Passive soiling,
Patient
yes.
will not realize. So always remember this important dictum, that if patient says that she has urgency and after that soiling occurs, that is mostly because of
External.
injury
External.
to external anal sphincter. Okay.
Yes.
So this is about the patient. Now, what investigation you would like to do for this patient?
Ma'am, so in this case, like now because we know better, we will just do the clinical examination,
Yes.
look at the sun raying pattern. So ma'am, we also checked the tone, we did a PR and we checked the tone also. But other than that, other investigations like transanal or transperineal ultrasound can be done to look at the sphincter.
Okay,
Yeah,
so
but
that
it's
can
not
be done.
essential.
But it is not
essential.
essential.
If you are working at a periphery, if you do not
Yes.
have an ultrasound machine, you don't have to send the patient to
Yeah,
higher center
not a necessity.
just to confirm.
Yes,
Yes,
ma'am.
ma'am.
You open it in OT, and I'm telling you exactly
It
at
is
that place you will get the
correlate, yeah.
sphincter.
Yes, ma'am.
Even if you just confirmation will be there, it is not adding into your
Management.
Yes, ma'am.
Okay.
Yes, ma'am.
One more thing, the other day we were discussing
Yes.
when we saw the patient, role of anal manometry.
Manometry. Yes, ma'am.
So what is the role of anal manometry?
Ma'am, so in this case, not so much, but you had explained to us that anal manometry is something that we can do at the postpartum state in order to see that if patients have a lower pressure at that time, then they can be given pelvic floor muscle training or some kind of adjunctive treatment.
So once patient has soiled, she
Yeah.
has complained of soiling,
Yes, yes.
then it does not add into just seeing that pressure are less. We
Yes,
already
ma'am.
know that pressures are altered. That's why patient is
Yeah.
soiling. It doesn't help
It
us.
can
We
be
have
a
structurally
prophylactic
said,
investigation.
yeah, it can be. It helps more in prophylaxis.
Hmm.
Like I was telling you, we conducted a few years ago a study on anal manometry
Yeah.
where we selected two groups of
Yes,
patients.
ma'am.
One who delivered by cesarean section,
Yes.
elective cesarean, without any trauma to the pelvic floor. Others were assisted
Instrumental.
vaginal delivery, either vacuum or forceps. And what we found that in women where instrumental delivery or assisted vaginal delivery was done,
Yes,
these patients had very low tone of their
Yeah.
sphincter as compared without any structural deformity
Yes,
also.
ma'am.
Yeah.
So what you wanted to say, I think the same
Yes,
thing,
yes, ma'am.
that these are the women who should be more aggressively told
About
the need of pelvic floor
Yes,
muscle
ma'am.
training from before only, rather than they developing fecal incontinence when
Later
they reach
in life.
menopause.
Yes,
ma'am.
Okay, so that is an important and interesting use of anal manometry.
Yeah.
But I think if you know that patient is already soiling
Mhm.
and you know the cause, that it is because of obstetric injuries, and you have seen that the sphincter is defective,
Yes, ma'am.
it does not
There's
add
no
on to
extra
the
help.
value.
Yes, ma'am.
Okay, so this was the patient. Now tell me, how have you managed the patient?
Ma'am, we posted her for surgery. We did a vaginal hysterectomy and a cystocele repair with a levatroplasty and with a sphincteroplasty. Ma'am.
Yes.
We did
So-
repair of the external anal sphincter.
So she had prolapse, she required anterior colporrhea, she required rectocele repair,
Yes.
and because on ultrasound we
And
saw.
TVTR.
Oh yes, of
SUI.
course, yes, ma'am. We also
So tension-free
yes.
vaginal taping, yes.
So when we saw that, we gave her an option, though she was, what was her age?
Ma'am, 55.
55 years old. So we gave her an option of uterine removal or conservation. She opted for, she had some fibroids, though she was menopausal, but after
Not
discussing,
symptomatic, yes.
she wanted her uterus also to be out. So we thought when we are doing this procedure
Yeah.
entire, we discussed with the patient and removed her uterus
Yes,
also.
ma'am.
Did repair of anterior vaginal wall, posterior vaginal wall.
Mhm.
For SUI, we did
TVTR.
Yes, ma'am.
Why we put TVTR for her rather than TVTO for her? Because many
Yes.
times we have discussed, still people keep on asking,
Yes,
so I
ma'am.
thought let's revise it once more. What is your criteria, Veera,
Ma'am,
to put TVTR?
one, depending if it's very severe, we go ahead with TVTR. If the patient is very obese, also we proceed with the TVTR.
So who will explain it to me? that what do you mean by if somebody have to check whether it is severe? What is the criteria that what tells you that patient has severe?
Ma'am, on the basis of history, any change in position, any slight change in abdominal pressure, if patient gives history that she turned in her bed or when she started to walk she's leaking, that tells us that it's a severe
she's
case of
sitting
S.
up,
And she gets up suddenly, that tells
Okay.
us,
So change in posture is minimal change in
Yes, ma'am.
intra-abdominal pressure.
Yes, ma'am.
If with even that, if
She's
patient is
leaking,
leaking,
yeah.
that means patient has
Severe SUI.
By examination, Veera, how
Ma'am,
do you know?
Well, once we ask them to cough, if it's a minimal leak, we know it's not severe. But if it comes as a parabola and
Yeah.
it leaks out, then we know it's
So
very
in
severe.
uniform cough stress
Stress
test,
test.
Yeah.
if it is just dribbling,
Dribble, yes, ma'am.
just drop by drop it dribbles, that means it is a mild case.
Mhm.
If there is a nice parabola and
Yes,
with
ma'am.
3 coughs,
Yes,
you
with
tell
3
them to have
coughs,
3 to
yes,
4 coughs. If with every cough she has one parabola of urine, stream of urine coming out, that means it is a severe case of SUI. These are the patients who are selected for TVT-R,
Yes,
which is a
ma'am.
retropubic technique. Otherwise, we prefer to do a
TVTO.
and if she is not very obese.
Right,
Yeah.
yes, ma'am.
Obesity also because TVTO needles
Yeah.
have a fixed diameter.
Yes,
Yes,
Sometimes it is very difficult
That
to
manipulation.
negotiate
Yes, ma'am.
in the patients who are obese or who have a lot of fat.
Yes, ma'am.
So this becomes more easy to do, so we do that.
Yes.
Okay, these are our criteria. So TVTR was done, you said, hysterectomy,
Yes.
anterior posterior repair, we are not going to
Yes,
discuss.
ma'am.
Some things do you want to tell about how do we repair anal sphincter?
Yes, ma'am. So, ma'am, in the case of sphincteroplasty, first thing we take a curvilinear incision. We take it above 3 o'clock and 9 o'clock position because we want to avoid any kind of vascular
So
injury.
we can say 2 to 10 o'clock.
2
or
to 10
to
o'clock.
2.
Yes, ma'am.
10 to, yeah.
Yes, ma'am.
And where exactly between the
Between the anal verge and the
Posterior
foreshape.
foreshape.
Yes, ma'am. So we take this curvilinear incision. It was around 2 to 3 centimeters, our incision. It is, ma'am, around maybe less than a centimeter deep. After that, we start to dissect, and we have to dissect the muscles and the fibrofatty tissue and isolate
on the lateral edges.
on both lateral ends
Okay.
in order to isolate the band-like structure, which is going to be our external anal sphincter. And when we dissect more in the center, we will also see a sheath-like structure, which is going to be the internal anal sphincter. Now, ma'am, through both sides, when we have the external anal sphincter, we took 3 bites in our case, one in the center.
So first you have
Yeah.
to dissect that.
Yes.
See, the rubber band has broken
Yes.
and
Yeah.
it has got fibrosis
Retracted
there.
and
Yes.
fibrosed. Yeah.
So what we have to do, we have to hold it with our Alice
Alice,
faucet
yes, ma'am.
or a cockroach
Cockroach,
clamp
yeah.
and dissect. You have to free little
Yes,
segment.
Yes,
2 to
yes,
3.
yes, ma'am.
Otherwise,
To
they
mobilize it,
mobilize. Otherwise, it will be under tension.
Tension.
Yeah.
And as soon as you close within 2 days, if any
will
solid
open up.
passes from there, it will
It is
open
going
up.
to open.
So it
True,
is
ma'am.
very important that it should be tension free.
Yes, ma'am. So we will isolate that, take it out, and then we took bites through that. So we took 3, and after that we tied them. Also, when we did this dissection, we went a little bit deeper, tried to feel for the levator muscle as well, and through the puborectalis, we took I think 2 more bites.
2 bites.
Yeah, to consolidate that further. Another thing that you told us we had done during when we saw the internal anal sphincter, we took some bites
There
through
was
that.
defect. It was also
Yeah.
attenuated.
Yes,
So
ma'am.
when we had opened also,
We just dissected through that a little bit so that the whole thing was a little more flexible.
and took some bites with number 2
Yes, ma'am.
cervical there
Yes.
also.
Yeah.
Now my question to you is, what technique it is called when you pull those rubber bands together
Yes, ma'am. So there
and
are-
suture? What is it called?
Ma'am, this is end to end. What we
End-to-end.
did was end to end, but there's also another one when we can do an overlap closure. But we wanted to avoid any kind of tension, and we did an end to end
So
repair.
if it is a fresh
Fresh
case
case.
Yes.
of OSS, immediately found post-delivery, detected post-delivery, and you are planning to do a sphincter repair, both methods are good.
Yeah.
End-to-end also and overlap also.
Yes.
Many people prefer overlap thinking that it will give a stronger and more lasting effect.
Yeah.
However, it is not always true. Studies have shown that both
Equal
repairs
efficacy.
Yes.
shows the efficacy is
Same and
same.
both,
There is tightening of equal amount,
Yes, ma'am.
but many people like to do that. But end-to-end anastomosis is very good, is
Yeah.
better for the chronic cases.
Yes,
Because now already fibrosis has happened. If you make it too tight, and patient is used to having this kind of incontinence for many years.
Yeah.
Yes,
4
ma'am.
years she is telling history of 6 months, but when the trauma has happened 20
Yeah.
years below, her sphincters are actually not that tight and
Yes,
firm.
ma'am.
Yes,
So
ma'am.
she will have unnecessary complaint of
Constipation.
constipation. So to make it simple, we just do
End-to-end repair. Yes, ma'am.
or end-to-end repair
Repair.
of this sphincter.
Yes, ma'am. Then we closed it. So we did a vertical closure, and when we were closing, while approximating the muscles, we also took bites through the superficial transverse perineal muscles
Yes.
on both sides.
Yeah. So and that was to make the perineum.
Yes,
Yes,
Because
ma'am.
perineum also was defective.
Lax and
Huh.
deficient.
Small, yeah.
Yeah.
So you told in the beginning that her this introitus was also very lax.
Yes,
So
ma'am.
perineorrhaphy, we combined this perineorrhaphy with
Yeah.
sphincter
Yes,
repair and did with single incision that. We have already, if you are not able to understand what we are talking about, you can go back and see one of the videos posted in anal sphincter repair posted by Dr. Supriti. It is not the same patient,
Yeah.
but you will get an idea what we are talking about because the principle remains same
Yes.
all the time.
That's also an end-to-end repair.
That also. Always, whenever chronic cases, I feel that it is better to
Yes,
have an
ma'am.
end-to-end
End-to-end
repair rather than going for an overlap
Overlap.
technique. And this patient was operated around a month ago,
Yes,
Yeah.
ma'am.
and she came to us last week
For a follow-up.
for a follow-up. Though I was expecting that okay, after anatomical defect repair, because she is having for such a long time, she will have 50 to 60% improvement. Then we will send her for physiotherapy for neuromuscular modulation. But how is the patient?
She's
She's
doing
doing
good, ma'am.
well,
No
ma'am.
complaints.
No complaints. Her urgency has completely gone. So you put her on some stool softener for
Yes,
some
ma'am.
longer time because, as I told you, her body is used to
Yeah, but
passing.
she has no
Yes.
complaints, ma'am.
She
Yeah.
does
Both
not
incontinence are sorted.
sorted out. So it was a very fulfilling case
Yes,
to
ma'am.
manage,
Yes, ma'am.
and it is very important learning here that if you see it separately from urology point of view, from colorectal surgeon point of view, from a gynecologist point of view, there are so many complaints
ma'am.
patient is having, and everybody will treat their compartment.
Yeah.
Patients'
Yes, ma'am.
complaints will always not be sorted out. So it is always a good idea to this kind of
To have
patient
a
to be
holistic
seen by
approach.
Yes,
holistic approach and seen by a
Urogynecologist.
urogynecologist who can see the entire pelvic floor
Yeah.
in totality and repair all the defects together. So patients usually will have a good outcome.
Yes,
Yes,
ma'am.
Okay. So it was a simple, straightforward case, I feel, with a
Yeah.
good outcome. So would you like to summarize some points which you learned today after this discussion? Who
Yes,
goes
ma'am.
first?
Anything.
Okay. Ma'am, what I really learned in this, that the history, the examination and the per-op findings were exactly same. Like in
For
history,
anal sphincter.
for anal sphincter, yes, ma'am. Like there was even in the history they said when she has a
Urgency,
transperineal with
History,
urgency.
she says urgency.
Urgency.
So you thought that it is, yes, there is some external
anal
yes,
sphincter.
ma'am.
Yes,
When
ma'am.
you saw this
On
was external sphincter, sunray
Yes,
was
ma'am.
absent.
Absence
Yes.
and ring from 9 to 3, and even introp when we dissected further, we saw the ends of the external anal sphincter at 9 and 3 o'clock position. Yes, ma'am, and further repair further.
Okay. So anything you learned?
Ma'am, yes, that anatomical defect should always be, we should first pay attention to that, and then physiological defect, it should be supplemented. And holistic approach. ma'am.
Holistic approach, very important, because why to increase when this pelvic floor is one problem.
Yes, ma'am.
If one person is saying, and even if some urologist is seeing the complaint of stress urinary incontinence, you should just have a look at her sphincter.
Yes,
Yes,
ma'am.
Many a times patients don't come up, they might be having problems,
Yeah.
but they are not open to their urinary incontinence is difficult to tell.
Yes, ma'am.
Yes,
Fecal incontinence is even more
Even harder,
embarrassing
yes,
to tell in front of
Yes,
somebody.
yes, ma'am.
And so, though there are so many patients suffering with all these problems, but they don't come
We
up
always have
easily.
to probe, yes, ma'am.
Yes. So that is our duty also to ask till the time the problems of the society
Yeah.
change their face and patient become more open to seek help.
Yes, ma'am.
So why we are not, as we always say, that problems do exist in our society,
Yes, ma'am.
but people are not coming up to the clinician to seek help, and that is because of, as we always say, that is because of unawareness.
Shame and stigma.
Stigma.
So there are three important causes: unawareness, shame, and stigma, and we want to see a different kind of future, so we have to talk about it. And if you treat 4 patients, they will spread the word to 8 new patients, and then maybe it is good for everybody to have a good quality of life. And I think that's the message we want to give at the end of this case discussion. So thank you all for your patient hearing.
Thank you.
Thank you.
Thank you.
Thank you, ma'am.